Oh, we're not going to be light. um,
We will. I have to do them like one at a time. So now I
Okay.
hit go
Okay.
live um on Instagram. Okay. Instagram. And we are live everywhere. You can take it away when ready.
Hi, everyone. So I am super excited. I've never done this before. So I'm going to do a live recording of the Muslim Sex Podcast. So welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about the new guidelines on the genitourinary syndrome of menopause. I thought I would come on and record an episode, and then, hey, why not do it live, right? So let's try it. So before we get into it, of course, as you know, with every episode, I always talk about that this is not any type of medical advice. If you have any questions about your health, make sure you go see your healthcare provider. And if you have any questions about your religion, make sure you go see your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I am going to bring to you the genitourinary syndrome of menopause. So as you know, as you may have heard, I'm not sure if you did, but if you follow a lot of the social media influencers, people that are really big on social media, like my friend, Dr. Rachel Rubin, the American Urological Association just came out with guidelines for the genitourinary syndrome of menopause. Now, this refers to a collection of symptoms and changes in the vaginal and urinary tract that occur due to low estrogen levels during and after menopause. So as we know, estrogen starts to go down and during perimenopause, and perimenopause, actually the estrogen can be a little bit erratic, a little bit like a roller coaster, but the end result is that it starts to go down. And in menopause, the estrogen is very low. This past week, the American Urological Association, like I said, just came out with some guidelines along with the women's health organizations, different women's health organizations, and they released a clinical guideline on this. The guideline explains how doctors should diagnose GSM, what treatments are recommended, hormonal and non-hormonal, and how to manage the condition over time. So below is, so what I'm going to be talking about now actually is just the key points that you should keep in mind when you hear the term genitourinary syndrome of menopause and what to expect during an evaluation and a treatment. So this is a medical term for the common symptoms that women can experience in the genital and urinary areas after menopause. Okay, it happens because the body produces such little estrogen and other hormones once menopause begins. And we know that along with estrogen, we know that the progesterone goes down, testosterone goes down. And so it's really important to know what's going on with these hormones. Without enough estrogen, we know that the tissues of the vagina and the lower urinary tract become thinner, drier, and less elastic. And so this can lead to a variety of symptoms that affect comfort with intimacy and urination. Definitely, when we have patients that come to the office or to the clinic, they may be experiencing a lot of pain with intercourse. And so, the vaginal and vulvar symptoms are dryness of the vagina and the vulva, irritation or burning, and pain or discomfort with intimacy, often called, well, which we call in medical terminology, dyspareunia. Some women will also notice some itching and irritation. And sometimes what will happen is that some women will notice that the vagina feels smaller or less flexible. And so this is really important because this often is what causes pain with intimacy. Urinary symptoms that women can have. So women can have burning or pain when urinating. So what we call that in medical terms is dysuria, and feeling like you have this urgent need to go pee and going to the bathroom more often to urinate and getting these recurrent UTIs. All of those things can happen as a result of this genitourinary syndrome of menopause. And this happens because the urinary tract tissue is also affected by the low estrogen. Now, other physical changes that we might notice as clinicians are paler or thinner vaginal walls, smaller openings, sometimes the labia will shrink and become smaller, narrow opening to the vagina, and changes in the pH. So a lot of women will notice that they may be more at risk for developing, say, yeast infection or bacterial vaginosis, because the pH, the vaginal microbiome, also changes during this time, which would, so the normal vaginal microbiome would prevent those infections and helps that. So it's important to know that this GSM, the genitourinary syndrome of menopause, is very common after menopause. And most women, and I'll be honest, I think like almost all women, right, as we go further and further into menopause, will experience some form of this. The good news is that it's definitely treatable and we have therapies to address it. And it is really important in improving the quality of life of women. In fact, I was just talking to the Rotary Club today, and I said, if there is one medication that I really feel changes the lives of women, is this vaginal estrogen. It really, really helps women. It prevents recurrent UTIs, prevents this pain with intercourse, and it really helps relationships. So I think it's very important for us as clinicians to address this. So let's get into like the details of, well, how do you go about diagnosing it, right? How do we as doctors go and diagnose it? So for the most part, this relies on, your symptoms, your medical history, and it doesn't really require much testing. What we do is we will do an exam, we'll do a physical exam, and when we do that exam, we take a look and we will be able to see whether or not you're experiencing these symptoms. And of course, you yourself as a patient will be able to tell us the symptoms that you've been having. It's really important to ask your provider, if you're having any type of vaginal symptoms, any dryness, burning, pain with intercourse, intimacy, that you go and you speak to your doctor or your provider about this. Make sure that you are open to discussing this, because when you discuss it, then you're able to get treatments for it, right? And a lot of times the treatment that we give you is based on what your symptoms are and how best we can treat you and what your goals are for the treatment. So remember to just kind of go over what's been bothering you so that you can tell your doctor about it. And we know that the genitourinary syndrome of menopause is linked to menopause, but remember that these type of symptoms can also happen if you happen to be breastfeeding. And again, my friend Rachel Rubin talked about this. She wrote a paper along with Dr. Jill Kraft about the genitourinary syndrome of lactation. So when we have low estrogen in our bodies, and that can happen when women are nursing, that they will actually exhibit similar symptoms to this pain with intimacy and this irritation and recurrent UTIs, because they also at that time have low estrogen levels. Sometimes we'll also perform a physical exam, which often, I think is really important to do. And I will always do a physical exam if somebody's complaining about vulvar symptoms. What we'll do is we'll just take a look. We know that the skin may be fragile, there's loss of elasticity, and there's definitely a change in the pH of the vagina at this time. So, we may notice some thinning, some atrophy, and that the opening may be tighter at this point. But if there's any pain at all during this exam, it's really important for you to tell your doctor, your provider, so that, we definitely don't want to cause any harm. We don't want to cause you any pain. So it's going to be important for you to let us know. With this, we typically will just do like a physical exam. There's really no lab tests or hormone levels that are needed at this point. It's really just based on your symptoms and really the exam. At this point, of course, we'll know whether or not you're in menopause based on the symptoms that you're having, but also, based on age and also your hormone levels. But we don't really need hormone levels just to notice that you are having these problems or issues. We we'll know just by the history that you're giving us, as to what is going on. Overall, if you're a menopausal woman and you're having these symptoms, it's definitely important that you tell your doctor so that we can help you. So now let's get into, so now that we just talked about, what the symptoms are, what the signs are, we talked about how your doctor is able to diagnose whether or not you have this genitourinary syndrome of menopause. It's important to know what treatment recommendations there are for GSM. So according to these guidelines that we have, there's various treatments and options that are available for GSM to improve your quality of life, right? And they fall into two broad categories. One is hormonal therapies, which address the hormonal deficiency and what's causing the problem. And then there are non-hormonal therapies, so for symptomatic relief. And yes, we would consider them more of band-aids and not really addressing what the real issue is that's causing this genitourinary syndrome of menopause, right? So as always, it always begins with shared decision making. And of course, there's no one size fits all for this GSM. The best approach is the one that's going to work for you and what you're going to be able to be consistent with, right? What your comfort is, what your goals are in terms of improving your sexual health and reducing the recurrent UTIs that you may be having. You want to start with effective treatments that work for you, something that you can be consistent with. Now, the gold standard is for the genitourinary syndrome of menopause, because remember, what is causing this problem? The cause is low estrogen. So if low estrogen is the cause, then we want to treat it with whatever the problem is. And so the treatment is usually local, low dose estrogen therapy in the vagina. And that's typically the first line treatment for GSM. Okay, that is what is recommended by the AUA guidelines. And because it directly treats what the problem is, which is the estrogen loss in the vaginal tissue. And of course, we know it has a strong track record of relieving symptoms safely. And but there are, of course, other treatments that are also available if for some reason estrogen can't be used or isn't enough. Sometimes what people will do is they will combine therapies. So typically we will, when you first start vaginal estrogen, we'll have you do it 2 weeks continuously at night. And then after that, twice a week for basically the rest of your life. For people that have started doing it twice a week, sometimes they want something in between those other days. And so they'll use vaginal moisturizers. And those vaginal moisturizers, a lot of times, will contain hyaluronic acid, which plumps up that tissue and helps moisturize that tissue. It, of course, does not solve the root cause of the problem, which is the loss of estrogen. So that's why sometimes some patients will use both. If they don't find, if they find that they're still having a little bit of discomfort even after the vaginal estrogen, then they might use a vaginal moisturizer. Pelvic floor therapy is always very helpful as well, because a lot of times, especially patients that have been suffering for a prolonged period of time with this genitourinary syndrome of menopause, they will have tight pelvic floor muscles. And so to help with that, we always will recommend that patients go see a pelvic floor therapist. Pelvic floor therapists are phenomenal. I wish somebody had told me about them earlier on in my professional career, because I think so many women could use them. And so they help so many women with those tight pelvic floor muscles, right? So really important. And so the therapies that we know of that we use is local vaginal estrogen. That's the first line treatment. Really, there's low dose estrogen therapy that's applied directly to the vagina. And the guidelines recommend that you initially start with this for GSM. And what we're doing is we're delivering small amounts of estrogen right to the vaginal tissue. This can reverse dryness, improve irritation, improve the pain with intercourse. It can also help reduce the urinary symptoms that women tend to face. It helps with the urethral health. In fact, women who have frequent UTIs after menopause will see fewer infections once they've been on this local vaginal estrogen. So vaginal estrogen comes in different forms. There are creams, there are tablets, there are suppositories, and even estrogen ring that sits in the vagina. So you have lots of options. If one doesn't work for you, you can definitely try another one. All of these deliver estrogen locally. So it's really important to know that. And according to the evidence, even though those studies were small, they consistently showed that vaginal estrogen makes symptoms better and does so with very few side effects, if any. I haven't heard of too many side effects. The guideline also highlights that low dose vaginal estrogen is very safe. It does not significantly raise estrogen levels in the bloodstream, so it does not increase the risk of breast cancer, uterine or endometrial cancer, heart disease, or dementia. So this is super, super important for those women that might be scared of estrogen, right? I mean, we have this whole thing with estrogen, right? Because of the WHI study that was published back in 2002, so many women are afraid, so many clinicians are afraid. In fact, I had a dermatologist ask me if, local vaginal estrogen was going to cause blood clots in her patients. And I explained to her that it would not, because it's a very low dose, and that risk is not there with the local vaginal estrogen that we prescribe. These are concerns that people used to have from older studies that have now been debunked. And because of this, even women who take full dose hormone replacement pills can also take vaginal estrogen safely. And if you have GSM and you want to try vaginal estrogen, make sure that you ask your provider. Other hormonal treatments that you can use if you have this genitourinary syndrome of menopause is vaginal DHEA. So that's called progesterone. That is the brand name. And so this DHEA basically breaks down in the vagina and is a precursor that converts to estrogen and testosterone. And this is a suppository, and it is for the genitourinary syndrome of menopause. And so this is also a reasonable option that can improve the genitourinary syndrome of menopause and the vaginal dryness and the pain with sex. And patients and physicians actually really like it. So, your patients have options. If they don't want to do the vaginal estrogen, they can do the vaginal suppository, the DHEA, which will also help that vaginal tissue. DHEA is a great alternative to those patients that for some reason decide they don't want to do the vaginal estrogen. This is fantastic. And the evidence suggests that it helps symptoms and also appears to be safe in terms of not causing any type of estrogen-related side effects. There's also something called aspafine, and it's an oral pill, and it's taken by mouth, and it acts like estrogen in the vagina without being a hormone. So it's a selective estrogen receptor modulator. It's another option to treat painful intercourse and dryness. The guideline gives aspafine a conditional recommendation, mainly because there is somewhat limited evidence and is not commonly used as a vaginal therapy. This means it's not typically a first choice, but it can be helpful in the right situation. So, for example, a woman who prefers a pill and doesn't like the cream, this is definitely an option for her. When women use systemic estrogen therapy, some women think that they do not need the local vaginal estrogen if they are taking, say, like a hormone patch. But it's really important to know that even if you are on like an estrogen patch and progesterone, that this therapy may not fully take care of this genitourinary syndrome of menopause. And so that's why your prescriber may prescribe both the systemic, right, the estrogen patch that you're giving, and given, and also the estrogen cream. So you may be getting both. And so for a lot of my patients, I actually prescribe the systemic estrogen along with the progesterone if they still have a uterus. Remember, you always need to take progesterone if you still have a uterus. And I will also give them the vaginal estrogen cream. And combining them is generally safe and can target the symptoms better. So it's really important that we have safety of these hormonal treatments, and the guidelines report that none of the GSM therapies, so those therapies that we just talked about, right? We talked about the vaginal estrogen, we talked about the DHEA, we talked about the pemifene, that none of them have been found to increase the risk of cancer, whether it was breast or uterine cancer or any serious health issues. So this is all super important because I know that this is definitely a concern for a lot of patients and also for a lot of clinicians. And they are meant to be low dose. They largely act locally on that vaginal tissue. So that is really important to remember. Because of this, right, we don't need to monitor with biopsies or scans to check the lining of that uterine tissue, because that lining should not be affected by this local vaginal estrogen that we are giving. And remember, we are only giving it twice a week. And you're only using a gram. So it's really not that much estrogen that you are using when it comes to this local vaginal estrogen. In other words, vaginal estrogen, or DHEA for GSM, does not mean that you need special cancer screening, right? Beyond your normal gynecologic checkups. And this is super, super important for women. Now, some women decide that, even though we have all these therapies, that they still do not want this local vaginal estrogen or the DHEA or the pemifene. They don't want to do any of that. And that's absolutely your decision. You don't have to. You can do whatever suits you and whatever you feel comfortable with. So there are some non-hormonal treatments, but remember, you're not really treating the problem when you're using these non-hormonal treatments, because the problem is that you have this low estrogen in your body, and that's why the tissue has changed. And so what we're trying to do is help that tissue go back to what it was. These non-hormonal treatments are not really going to help the cause of what's causing this gender urinary syndrome of menopause. So you can use a vaginal moisturizer, right? We talked about that. So you can space it out. You can use it in conjunction with your vaginal estrogen. But if you don't want to use the vaginal estrogen, you can use moisturizers. And if you are using the vaginal moisturizer and not using the vaginal estrogen, you can just use the vaginal moisturizer daily if you want, or a few times a week, whatever suits you. And it's applied to the vaginal area to help maintain moisture. Like I said, a lot of them do contain hyaluronic acid, which is there to help plump up that tissue. These are not hormones, and they will not replenish some of the problems that you have with gender urinary syndrome of menopause, which is that overactive bladder, which is that recurrent UTIs. It's not going to do that. It's just going to help with moisture. So that's really important to know and realize what you're using and what it's being used for. Lubricants are always helpful for, intimacy. They can definitely help with discomfort. But remember, again, if you're using a lubricant, it's only during intimacy, and it's not really going to help outside of that. And it's really not taking care of the problem that you're having. So just important to realize that. Pelvic floor therapy, of course, pelvic floor therapy is amazing, helps with so much. Women have tight pelvic floors that can cause pain, especially when they have gender urinary syndrome of menopause. And they will be really, really helpful. But again, they are not going to be able to treat the root cause of the problem for GSM, which led to the painful intercourse and the secondary pelvic floor muscle tightness, right? Or the anxiety. Remember, a lot of women can develop vaginismus due to the pain with intercourse. And remember, vaginismus is when the pelvic floor muscles tighten in anticipation of any type of penetration, whether it's pelvic exam, whether it is tampon insertion, or any type of penetration. You're going to have that pain. And so if you're having pain, sure, pelvic floor therapy is fantastic, but you have to look at, how that pain started. That pain may have started because that tissue was really fragile, was prone to cuts and irritation and itching. And so it's not really taking care of the problem. So I would use pelvic floor therapy in conjunction with vaginal estrogen. I think that would make a great pair. Lifestyle and other recommendations, the guidelines advise against using unproven supplements or things that irritate the vagina. For example, herbal supplements or douches. Oh, douches are awful. They're going to change the vaginal microbiome and make that vagina even more irritated. Gentle care of the vulvar region with just soap and water is enough. You want to avoid irritants like perfumed products. And, if you can, continue to have intimacy, that's fantastic. But oftentimes I find that women are so uncomfortable that they just don't want anything to do with that. The key thing is to avoid irritants that are going to make this worse. Okay. Now, I had a friend of mine that had asked me about laser therapy to help women with this gender urinary syndrome and menopause. And a lot of laser companies will advertise for using this type of therapy. So I'm sure you've heard of it. And these devices are marketed to treat vaginal dryness, like CO2 lasers or other energy devices, where some women will say that, women can have vaginal rejuvenation. So the AUA, the American Urological Association guideline, reviewed these and found that there was not enough evidence to support using these energy-based, so basically lasers, for GSM at this time, right? And in fact, these treatments are considered experimental. So that's why it's really important to know, if you're having this issue, what is it that you're going to use to help resolve this issue, and what will be the best bang for your buck? And, one of those vaginal treatments are pretty expensive as opposed to local vaginal estrogen that will actually treat the cause of the problem and help you and give you some pain relief, right? So in summary, right now, treatments for GSM, these laser treatments are not, the recommended treatments are hormonal and non-hormonal rather than lasers or devices. So that's what we have right now. So in terms of managing GSM over time, so generally it's considered to be a chronic long-term condition. And this is, in fact, I gave a lecture on menopause today, and I was telling the people that were there that, this genital urinary syndrome menopause, starts to develop early on, right? And it actually will get worse throughout time if you do nothing for it, if you do nothing about it. It's just going to get worse. So it's really important that if you are suffering, first of all, there's no need to suffer, but if you have a lot of issues with this, then I would really strongly urge you to get treatment if you're able to get treatment. And because it's just, honestly, it's going to get worse. So these treatments can really improve your quality of life. And so once you get started on local vaginal estrogen, you want to make sure that you follow up, that you get reevaluated by your healthcare provider. It's not like you have to go back like every 2 weeks or anything like that, unless you're having other problems, like there could be, maybe you have lichen sclerosis, lichen planus, other things like that you need more frequent follow-ups. But if you have gender urinary syndrome of menopause and only this, then you can go in a month later, or you can go in as often as you like. And if it's getting better, then you can space out those reevaluations. If it's not getting any better, then I would go back and get reevaluated to see what they can add to your treatment to help you feel better. Again, there's no special surveillance that they noted that you needed to do if you were on this local vaginal estrogen. Again, you don't need to have your, the lining of the uterus measured every so often, because remember, these are local hormones and they do not increase the amount of estrogen in your body very much. The data shows that they do not increase the risk of things like endometrial hyperplasia, like endometrial cancer. It does not increase that. So you don't need this routine surveillance just for this, right? So if you're just going for this local vaginal estrogen, you don't need increased surveillance because of this. So adjusting treatment over time, you may, your needs might change. Maybe some women find that, they're okay with just the local vaginal estrogen. Some women think that, decide that they would like to use a moisturizer in between those days. And we talked a little bit about that. It's all about shared decision making and what it is, what are your goals, and what do you want to do. Remember, this is all about your quality of life, ongoing support. You want to have a relationship with your clinician so that you can talk about the things that are going on in your life, and together you come up with a treatment plan that fits you and fits your life, right? So the ultimate goal of treating GSM is to improve the quality of life. This includes physical comfort, intimacy with your partner, sexual intimacy, and definitely emotional support. A lot of women think that there's something wrong with them, and they suffer with this for so long. In fact, there was a story in The Guardian that came out, I believe, earlier this year in January, that talked about a woman that quit 4 jobs just because she was suffering with this gender urinary syndrome of menopause, and nobody was able to treat her where she was. Nobody understood what it was. You remember Halle Berry? She also talked about this, how she was suffering with this gender urinary syndrome of menopause, and her gynecologist actually thought that she had herpes, which she did not, but he misdiagnosed her. So it's a lot of times, if physicians don't know, it's important that you can print this out. So you who's listening to this podcast, you can print out these American Urological Association guidelines. You can share them with your clinician. You can share them with your doctor. If they haven't seen them, they should see them. They should read them so that they know how best to treat you, how to help you out. So that's going to be really, really important. And, with proper treatment and management, women can remain symptom-free and really improve their day-to-day life and their relationship. I mean, it really saves relationships. So really important that if you are suffering, there's no need to suffer. You can go and get help. And this is really what this guideline says, right? So the American Urological Association guideline on the gender urinary syndrome of menopause really talks about how GSM is common, it can be easily treated, and is a very treatable condition. In menopause, women do not need to suffer. Diagnosis is usually straightforward and is based on, the patient's symptoms, the vaginal dryness, the irritation, the pain with intercourse, the recurrent UTIs, the overactive bladder. Women can go and get evaluated with the symptoms. Doctors a lot of times may do an exam or they may not, but for me, it's always good to do an exam so that I know what I'm treating and I don't just go based on what I think it might be, right? Of course, it's always very important to get assessed. You can talk about, along with the vaginal estrogen, you can talk about the moisturizers. Always important that if you still have pain, that you use a lubricant. With sex, there's nothing wrong with that. And shared decision making is really, really key when it comes to your health, when it comes to hormones. It's really important to find a provider that will listen to you, that will take time for you. And that's why, really, honestly, concierge medicine works so well, and it melds so well with the osteopathic principles as well. I'm a DO, and the DOs really believe that the mind and body and can really heal itself, that the body can heal itself. And with time that you spend with your physician, it gives you time to understand what's going on. Physicians are able to spend time with you and really go over everything. And they can go over, excuse me, they go over signs and symptoms, they go over treatments. Sorry. And it's really important that you get the treatment that you need in a timely fashion. So if you are suffering, no need to suffer. Oh gosh. The American Urological Association has put out these guidelines for everyone, for clinicians, for patients, for anyone that needs help, that is suffering. There's no need to suffer. There are guidelines. There's help available to you. And so many people are ready and willing to help you. So that is it. I thought it was really important to come on and discuss this. These guidelines just came out on this past Monday, and I am so proud of my friends that were part of this research, part of these guidelines that have put them out to really help and improve the lives of women. So if you are suffering, no need to suffer. Go and see your doctor or provider and get treated. So, well, we are done here, and I'm really excited because this was my first live podcast. So really excited for that. And for all of you that may have tuned in, thank you so much for watching. And well, I am done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you have any questions about your health, please go see your healthcare provider. And until next time, this is the Muslim Sex Podcast.